3 previous lectures with wonderful thinkers and practitioners sharing what decolonizing global health means and what is necessary to make our world, community of health professionals, and everyday interactions more equitable and just. Today, it is our great privilege to meet with 2 leading thinkers, engaged scholars, and practitioners working in health systems and policy research in South Africa. Professor Lucy Gilson is a professor of health policy and systems at the University of Cape Town. She's worked there for over a decade, but worked in South Africa for 25 years while holding a position at the London School of Hygiene and Tropical Medicine in the UK. Her innovative scholarship, activism, and mentorship is deeply respected within the community of health policy scholars throughout the world. Professor Gilson's more than 30 years of scholarship has contributed to building the emerging field of health policy and systems research, or HPSR, and seeks to understand and improve how societies organize themselves in achieving collective health goals and how different actors interact in the policy and implementation processes to contribute to policy outcomes. She's particularly interested in how health systems contribute to broader social justice and in the dynamics of decision-making within health systems, including the politics of health policy development and implementation. What an honor to share this space with you, Professor Gilson. Professor Mosa Moshabela is an associate professor at the Dean in the School of Nursing and Public Health at the University of KwaZulu-Natal and adjunct faculty at the Africa Health Research Institute in South Africa. As a family physician and generalist primary healthcare practitioner, Professor Moshabela has broad interests in health systems with a focus on services, research, policy, and implementation science. He thinks broadly and deeply through his research, doing work that is truly trans and interdisciplinary in its motivations to improve access, quality, and equity in and through healthcare in sub-Saharan Africa. Much of this work involves the design, implementation, and evaluation of complex interventions in public health care services and programs. For example, Professor Moshabela works within the concept of people-centered health, as opposed to disease-centered health, which is common in biomedicine and public health generally. He's currently leading a team to establish a new research institute focused on research for societal impact, the Institute of People-Centered Health. Other accolades include serving as chairperson of the Standing Committee on Health in the Academy of Science of South Africa and serving as a member of the Lancet Commission on synergies between health promotion, universal health coverage, and global health security. What a privilege to spend this time with you, and thank you for joining us. So this forum today will involve a moderated discussion, a little bit different than our previous forums, with questions submitted from our students, which I've modified and reorganized a bit. We will also be fielding questions from the YouTube chat, so please send them our way, and Professor Claire Stanley will be asking them along the way as they fit in. So we'd like to begin by asking our speakers to introduce themselves in greater detail and describe what drew them to thinking about and devoting your careers to working on health policy and systems research. I'd like to ask that you also speak about what decolonizing global health means in relation to how you position your work, your mentorship, and your projects. So whoever wants to go.
I'll let Lucy go first.
Thanks, Mosa, and thanks so much, Emily and Claire. It's great to be with you all. Hello to everybody as well. So I hold a British passport, but I've been privileged to live the majority of my life in different parts of Africa, and as Emily said, the last 25 years in South Africa. I would describe myself as an accidental academic. It wasn't a career path I set out on when I left university, but I've ended on it. And I'm a social scientist working in the health sector. My basic training's in development studies. I'm not a disciplinary specialist then. I've seen the inside of a government, having worked once as a health planner in Swaziland. And I've closely observed and accompanied public health systems throughout my research and training. I suppose, in essence, I really do have a strong concern for social justice, and I think that health systems matter to developing social justice. And I recognize health systems as being socially and politically constructed. So they are both sites of contestation and sites of opportunity to engage over social justice issues. My broad concern is to think about how to strengthen health systems to promote social justice, and my practical concern is how to change decision-making practices within systems towards that goal. Now, with respect to decolonizing global health, I am a self-confessed health policy and systems researcher, and as such, I guess I seek to raise some different issues in global health debates to those that are dominant, and to bring some different perspectives to those debates, but doing that at national, regional, and global levels. I also try to bring experiences from South Africa to those different places, and to work with others in other low and middle income country settings to learn together and to bring that shared experience to the table of global health. Part of what I think is important in global health is working collaboratively on an equal footing, and with partners in government, with partners in civil society, as well as with partners in other countries. In my teaching, I try to particularly bring African experiences to the fore of that teaching, to bring a range of authors in, to bring explicitly political perspectives in, to think about history, philosophy, as well as other social science traditions, and through the teaching to bring these perspectives to the attention of others. I deliberately and purposefully have sought to work with and strengthen low middle income country networks, to catalyze the spread of ideas, to catalyze assets within academic and health systems. And fundamentally, I'm a person with multiple privileges who's been around the block a bit, and I try to acknowledge my own power and find ways to spread it and share it, as well as to leave it to one side when I can. Thank you.
Yeah, so my name is Mosa. You guys can just address me as Mosa. And I think professionally, maybe it makes sense to sort of explain that I was trained as a clinician, as a medical doctor, and specialized in family medicine. But I haven't sort of been actively practicing clinically for some time now, and it's as a consequence of the journey that I've gone through in terms of how one might be able to make a difference. So I grew up, of course, wanting to be a doctor and wanting to help people, like most people would say. But then I sort of quickly realized that as a doctor, I can only do so much. I can help the person in front of me. But the problems that I was dealing with when I was a clinician had to do with the fact that you can see a patient today, but you don't know if next month when they're supposed to come back for a follow-up, that whether you're going to see them or not. And I felt quite powerless in terms of being able to address the issues that affect patients' ability to maximize use of healthcare. And so I started to drift a bit towards sort of thinking about issues upstream that affect the sort of essence of and the success of clinical care. But of course, when I started off kind of pursuing my clinical career, I didn't know these things. I only learned those things later on when I was in practice. But perhaps to go back even before that is to say that I grew up in a rural area and in a village until I finished my high school. Even all of my high school, I did them in a village. And so when I left high school, I couldn't really speak English. So I had to learn how to speak English when I was at university. So that sort of informs a lot of my thinking because as a clinician also, I spent 10 years working in rural health. And when I became an academic, I also spent several years as chair of rural health. So issues of disparity have really underpinned a lot of my thinking and what I do and sort of how I engage with the world. but also just in as much as, now I live in a city and all of that, it's true that you can take a man out of the village, but you cannot take the village out of that man. So a lot of what still informs my thinking is the experiences that I had growing up. So, and the way that I try to explain it is to say that I grew up, as a disadvantaged person, but now where I am, I'm very privileged. But in my privilege, I try to get the previous disadvantage to basically help inform how I navigate that privilege today. And so that basically leads me to my next point, which has to do with this issue of decolonization. And I see it more through the lens of privilege as well. But there is, on the one hand, sort of intentional harm that comes with colonization and issues around decolonization that have to do with intentional harm. That's not necessarily what I want to focus on. I think that's a different issue. I think my interest is in the sort of unintentional, the blind spots. And when I think of decolonizing, I'm much more interested in peeling back those layers and layers of blind spots that we have because of our privilege, so that we do not necessarily cause unintended harm. So that's sort of what I'm interested in when I engage with decolonization in global health. I use a very different method when I deal with intentional harm. And yeah, you don't really want to cross my path when there's intentional harm. But I think I'm more gentle when I deal with unintentional harm. And I think also, just to say that I think for me, in terms of health systems, I also, as I said, started off as a clinician. I didn't expect that my career will sort of pivot into health systems and health policy. But naturally, when you are dealing with patients in front of you, you start to realize that there are upstream factors that affect what you do in that consulting room. And when you then kind of make a decision to empower yourself to address and resolve those problems that are upstream in order to enable what happens in the consulting room, is sort of what led me down that path. And it happened because of HIV. Many of you may know that the effect that HIV had. And South Africa had a very unique particular experience with HIV that necessitated for a lot of us who were clinicians to start to kind of adopt more activism, so to speak. And because of that, then we had to learn how to engage with higher level issues. And so that's when my path kind of led to that. And I think that one of the issues there to note, and we see it today with COVID-19, is this issue of navigating uncertainty. When you're dealing with a condition that you don't quite understand at the time, you don't fully understand, and there's new evidence that is emerging, there's a risk that we fill in the uncertainty with a lot of things that can be harmful. So HIV did that for me, and I've used those lessons now when we're dealing with COVID-19. The next one is complexity. And just to say that one of the reasons why I'm a complex thinker, and I see myself and I identify as a complex thinker. And I think that is an asset. And I draw from different disciplines. I draw from qualitative methods, quantitative methods. I draw from social sciences. I draw from basic sciences, from clinical sciences, population sciences. And I mean, I'm still learning how to engage with economic sciences, but all of that, I try and bring them into the way I think and deal with the problems that we engage with. And those kind of frame my approach and thinking, and you may see them pop up as we discuss. Let me pause there. Thanks.
So the next questions that students have posed are both, I'm going to actually clump three together because they are bringing together ideas you guys have already talked about. So the first question is, how do you tell the difference between a good health system and a bad health system? But then there's also these questions. The second question is related because it asks, how do you think about leadership and governance, and how do leadership and governance play into power and privilege around health policy decision making, or what leads to a good or bad health system and what that means? And the other question that can't really be dissociated from this, and I think you both could talk an hour each on this question, is really how do you deconstruct the role of the system and NGOs and colonialism and these legacies that are embedded and surrounded in present day structures in which people seek to live healthy lives and good healthcare? I think they're all interrelated. So I wanted to clump them together just to make it more complicated.
Yeah, no, thanks, Emily. Lucy, you go first. I'm still
Over to
thinking.
you. You're still thinking. Well, so let me start with the one about good and bad systems, because my immediate response was, in a way, well, whose judgment of good or bad should we be thinking about? You know, what do we mean by good or bad? And we'll have different views on that, I would think. I guess I would like systems that work to serve the public good, that work to promote equity in health, that are accessible easily by all, where there is no payment to access. Those are the sorts of systems I want, but they reflect my own value judgments. So when we're talking about an ideal system, which is another part of the question, I'd also say, well, there's no ideal system. There's only a system that's in progress. There isn't an end point in systems. They're continually evolving. And in thinking about how you then develop or strengthen systems, you have to think about the processes of decision-making with respect to the next evolution of a health system. And those processes of decision-making are processes of power, the use of power. We have to think about how power is balanced. We have to think about whose interests are being served in decision-making. And that's all the stuff that is to do with leadership and governance as well. I'll make one more point before I hand over to Mosa. I think in health systems, you know, they're called health systems, but they're really clinical systems, perhaps. There's a biomedical dominance within most health systems. Our ministers are called ministers of health, not ministers of well-being. All of that signals certain things about what and who has power within health systems. But those health systems are nested in societies, and societies have different power distributions as well, that we have to consider as forces that influence leadership and governance. And health systems are nested in global systems. And then we have to think about the global forces that influence what is seen as a good or bad system, how a health system evolves. And we have to think about how those global forces are harnessed to have impact, or perhaps are not harnessed to have impact on how the systems evolve. I'm going to pause there as long as Mosa doesn't talk too long. Over to you, sir.
Thanks. So maybe, Lucy, I should pick up on the point you make about whose judgment and not wanting to impose your own value judgment. And I think, for me, I think that's really the core of the question that we have to kind of highlight and talk about in global health, and particularly in decolonizing global health, is the idea that somehow what we value is important, and is more important than what others value. And naturally, we try to assert ourselves by imposing those value judgments on other people. And as I said, that some people might do this intentionally, like we may see with evangelism. And I'm a Christian, I grew up Christian. I don't necessarily mean to attack, but I'm using that as an example. But other people do it much more, you know, sort of from a place of ignorance, so to speak, without realizing that that's actually what they're doing. But the ability to be able to think about this and reflect on it, and ask yourself, what your values are and how you might be imposing those values on other people really is powerful. And to take the time to actually ask people what they value and understand what they value and be really careful not to erode their values. I think for me, that's really important. And I have had the fortune of, even though I was trained as a clinician, and even though I grew up in a Christian family, a lot of the patients that I engaged with, I found that they engage with traditional healers. And naturally, from a Christian perspective, you are taught to, ridicule, undermine, and dismiss, and, all the negative words you can attach and connotations you can attach to traditional healthcare. But at the end of the day, I started to realize that that's me imposing my beliefs on someone else. And yet I am there to serve them. So who am I serving then? Am I serving myself in the way that I engage in the consulting room with the patient? Or am I serving the patient? And if I'm serving them, then what effort am I going to make to recognize, acknowledge their beliefs? I mean, there was a moment it hit me when I was working in the children's ward as a young doctor, and there were all these mothers who brought children to the hospital with what we called herbal intoxication, and they had ingested traditional medicines. And the first thing is to shout and whatever and get upset and how could you do this and so forth. But alternatively, you could sit down and try and listen and understand where they're coming from. And through my training in family medicine, where we were being taught to listen and understand, and in family medicine, we adopted the philosophy of holistic care, biopsychosocial approaches. And they sort of went to extra mile, teaching us how to communicate, making us unlearn the way we had learned to do consultations with patients when we got our MBCHPs, and teaching us to learn new ways of engaging and listening. So through that, I was then able to take the time to listen, and I ended up doing a study, but I started by listening. And I actually understood the depth of the beliefs that were entrenched in the way people engaged with traditional healthcare, and the philosophy that was much broader than what I understood. And so I actually started to learn, and the more I read about it, the more I started to learn. And I actually realized that actually I didn't have to believe in it myself, but I could just acknowledge that that is the beliefs and the practices that my patients had. And I therefore had the duty to learn and understand it, not to understand it so that I can find best ways to argue and dismiss it, but so that I can better understand where my patients were coming from, why they were doing things the way that they were doing. And that kind of shifted the way I engaged with healthcare. It shifted the way I looked at health systems. Health systems were no longer just clinics and hospitals. And mind you, patients who come from those kind of beliefs see clinics and hospitals as little colonies of Western practices and Western ideology. And they come to them because they have to. And you may think that those clinics and hospitals have been there for a long time, therefore they are part of those communities. No, they are little islands in those communities at times. And so the moment you start to understand that, you understand the shift of power. The moment a patient walks in through the consulting room, you understand the shift of power. And that power was reversed when we engaged in HIV care. And all of a sudden, I had to go to the patient's home to do a home assessment. Now, when I got to the door, because they take their shoes off at the door, I had to take my shoes off. And they wanted to give me the privilege of walking into the house with my shoes off, but I decided, no, this is what you do, I'll do what you do. And you listen to the conversations, you can hear now that the power has shifted. The patient is now able to make demands and to basically tell you what they value, what they want. And so the consulting in the home is very different to the consulting in the consulting room in a hospital. And so in a way, then that shifted the way I thought of health systems. And now I want health systems to include a household. I want them to include a home as part of whole health systems, not just clinics and hospitals. I want health systems to shift their thinking from just being curative, which is what Lucy is referring to, that the emphasis on clinical medicine, the curative medicine, to actually promote prevention and promotion of healthcare, and to also just think about how we work out ways of making sure that people have power in the way they engage with us as clinicians. They must not necessarily feel that their power has taken. So, and engaging in those empowering consultations should not necessarily be a zero-sum game, whereby as a doctor, all of a sudden that now I feel like I'm disempowered because there is sort of leveling and evening out of power with the patient. No, but because we are so used to having that power as doctors, then it's hard to let it go. When I have to go to a patient's home, I still want to go in with the power that I have when I'm in the hospital. But the situation kind of changes. So I want that situation to change when we think about health systems. We were trained, and this is my last point, Lucy, we were trained that as doctors, we save lives. And it wasn't only until recently when I was kind of engaging with people in aging research that I realized that actually we were wrong to think that we need to be training doctors to save lives. I think that health is not necessarily about saving lives. That is just a part of it, and actually a small part of it. I think a large part of it, in my view, should be about restoring dignity for people. If we kind of think that being sick kind of takes away something from the patient, it takes away their power, it takes away their independence, it takes away so much, and therefore erodes their dignity. So if I think that we need to think about how we help people restore their own dignity in the way that we engage with health and healthcare and health systems. And for me, that is a broader kind of way of thinking that goes way beyond the way we understand the technology of clinical medicine and curative medicine. So, and I'm happy to engage further on that. It's something that I'm still developing in the way that I think about health systems and healthcare. But part of my interest in people-centeredness has to do with that, to say that let's try and restore the dignity of people and not necessarily think that we are here to save people's lives. Thanks.
Lucy, you're muted.
Yeah, can I pick up on that? I want to sort of build on what Mosa has said, to think about the global relationships. So, if we start with the idea that we have to reorient the way we think about health systems and respect and work in health systems from a position of respect, that has to extend into the global relationships as well. And instead of global actors coming to countries with the answers, it is important that the way global actors engage with countries is to work with the answers that pre-exist them and with the situations into which they work, and to start from that place rather than a presumption of what the answer to health system development is. Health system development has to be enabled within context, not imposed from outside. Thanks.
This is all really building on these ideas. I mean, these ideas of dignity and building kind of community and individuals, but also kind of communal levels of dignity. And it builds also on the questions around what forms of capacity strengthening are needed in developing health systems capacity, and is there a role for global health organizations in such capacity strengthening?
So I'm going to grab this one because this is an issue of very close to my heart. It's not a mental issue, it's a heart issue. I really that when we think about capacity strengthening, it is in global health debates, there is often a sort of glass half empty approach. We have to fill the glass up. And we ignore the fact that every country has assets, every system has assets. There are knowledge, traditions and histories. There are people with skills and competencies. And the challenge is to multiply and to nurture and to strengthen the assets that exist. And capacity strengthening should, in my view, adopt that sort of a focus, and should be conducted with an awareness of systems. It's not about building individuals. It's about engaging people within networks, within systems that will sustain and reproduce themselves over time. And the systems that are important here are both education and health systems. They are government and academic systems. It's not one system, it's the interconnection across these systems. And it is important then that we don't think about supply and demand, which is sometimes the language used. We don't think about, promoting heroic leaders, for example. It's important that we think about distributed leadership in systems. It's important that we think about nurturing, not building, as if we're building a building, as opposed to working with human beings and human capacity in all its richness. And I think that has implications then for how funders think about funding, global funders think about funding, domestic funders think about funding. And I think we need more networked approaches to capacity strengthening. And I've had the privilege to work within some of those networks and see the multiplier effect of people engaging with each other and learning together, and learning through doing, so that there is a growth of capacity as an asset for a system. What's your thoughts, Mosa?
Yeah, I agree. I want to sort of go to the sort of smaller level, more the individual level about this. And that is, in 2010, 2011, I had the privilege of spending 3 months at Columbia University with the Millennium Villages Project. And I actually ended up working with them for about 2 years in West Africa and parts of East Africa. And I don't know if you guys know about the Millennium Villages Project, which was a UN Millennium Project, which was sort of built around development and the effort to try and eliminate poverty and ideas around that. I think if you haven't really looked into it, please look into it. It's a very interesting concept. And in practice, of course, it's much more difficult, but it was a project led by Jeffrey Sachs. Now, at the time, I was being recruited to be the sort of health systems director for the project in the different countries where it was being implemented. It was being implemented in 10 countries, and the head office was in New York. And I decided to spend time there first, just watching and looking at how people were engaging. Now, I think one of the things that struck me was that at the end, I decided not to take that job. I didn't want to work in New York because it was so disempowering to be at the head office in New York with very smart people that are recruited from different parts of the country and different parts of the world. Very smart, young people, very articulate, but with very little experience of what's going on the ground. And for me, I'm sitting and we are on a call and we are speaking to someone who is in Senegal or who is in Kenya, who is dealing with the challenges on the ground. And I had no idea. And I struggled with that. And what I ended up doing though was accept a job to be their health systems advisor for West Africa, for 4 countries in West and Central Africa. because I felt that was bringing me closer to the ground. And before I took that job, I asked for a visit. So I went for a 1-week visit to Mali, where I looked at their project before I decided to take it. And they took me around, I engaged with people, and then I was assessing whether I could add value or not. I mean, I had no doubt in my intellectual capacity, but it wasn't that. It was just how that is going to connect with the reality on the ground. That was my challenge. And so after spending that time, I realized that I had so much to learn from the guys on the ground. Now you need to come in as an expert and advise people. But at the same time, there's so much you need to learn from them. You know so little about the reality on the ground. And yes, I've lived in Africa, in African countries, but the reality that they were facing on the ground was different. And I had to assimilate into that in a short space of time. But more than that, I had to tap into their experiences and their understanding. It's very disempowering, I think, when you are so-called expert in a senior position, advisory position, and you have to work with junior people on the ground, right? Who are trained less than you, but they know more about the reality on the ground. And you see it when we deal with community health workers. You see that. They have so much richness in their knowledge of the context and reality on the ground. But to be able to find the humility in myself to say that I don't know the reality that you face, I need to learn, teach me. That was hard. It was a humbling experience. And now for me, I feel that that training is missing. The training to be reflexive. And in qualitative and social science, they talk about being reflexive in qualitative research. The training to be reflexive, to be able to get out of yourself and really and listen to other people and understand their reality. And not necessarily just come in as an expert, but recognize that they have expertise. For me, that is something that is challenging. And I've had to learn about transformative learning theories because of that. And I adopt those transformative learning theories that intentionally create dilemmas for people who are learning so that they can early on learn that you have to be intentional in recognizing that there are assets in someone else and other people, and be willing to reach out and tap into that. And if they need help in terms of you bringing the best out of them, that you have the capacity to be able to do that. That for me, I think is missing. And I'll pause there, but I think it's something that I just want to flag as I hear all of these grand things, and you can read about histories of so many other things and have so much knowledge, but that sort of skill, I think it's, and I don't know whether it's nature or nurture, but for me, I think I went through it, from the perspective of nature, to be able to try and find a way to reach people and be able to tap into their assets and their expertise.
I'm trying to figure out what to ask next, because we have 20 minutes, and I'm going to end with a question about how we might reimagine how these power dynamics look like and what decolonizing could do, and how we reimagine health systems, health systems. But before I get to that, I want to talk a little bit about power and privilege. I was wondering if you could speak a little bit to, and these are themes that we had all these nice, neat questions, but that always kind of dissolves once you guys have already touched on everything in different ways, in such more thoughtful ways than I could have ever thought of. But how do we think about power and privilege as students, as people interested in global health from the United States largely, or maybe people on YouTube are from all over the world. But how do you think of power and privilege as students, but also in financing and the ways in which global health is structured today, with so much power in tech, as it always has been, but shifts and moves. But how so much power is in technical assistance and lives in, for example, Bill and Melinda Gates or all of these different international NGOs. And how does that power and privilege translate to a place like South Africa that has a larger public health sector and is different than a place like Mali, like you were talking about, or a place like that may be more dependent on international aid? And how is that navigated? Or what do you recommend? How is it done? How should it be done? It's a big question.
Lucy?
Just a teeny question.
It's-
Mosa, I'm thinking, have you got an immediate response?
Okay, I've got one part of it in terms of responding to the question. And I think, so let me start with the issue of privilege. And I kind of want to turn it on its head. And again, by telling us a story. So sometimes we would get students from Duke University coming to Durban to visit, and we'll chat to them. And I've got a colleague, Bernard Gede. He's a white, middle-aged male who is got kind of roots from Germany, and he's got like beard and stuff. And I hope you can imagine him. But he's also someone who spent a lot of time in rural health. So we kind of have intersecting thoughts around issues of disparity. And so at some point we were talking to these students, and I said to them, as we were talking, to them, I said to them that, have you guys, can you guys believe that Bernard, this white, middle-aged, bearded man, is more Zulu than I am? Zulu is like ethnicity or tribe or whatever you call it in KwaZulu-Natal. And I grew up in the north of the country, and we speak Pedi or Sotho. So it's a different language, it's a different culture that I was immersed in. But Bernard had been working in KwaZulu-Natal for about 15 years. And the Zulu culture is unique as well. And he was immersed in it for a long time. And so I said to them, to the students, that, I actually think that Bernard is more Zulu than I am. And of course, their eyes popped out. And one reason for that is that when you're thinking about a Zulu man or a Zulu person, you're thinking of a black-skinned person. Now, it didn't make sense that when I'm the one who's black, he can be more Zulu than I am. But what I was trying to show here is that he has had more privilege of immersing in the Zulu culture and history and nuances of the culture than I had. And I had to recognize that. And if there were things about the traditions, about the Zulu culture, I would defer to him because of that immersion that he has had, not because of the skin color. And so, and this is how we thought of rural health as well, is that people think of rural health more from the perspective of deficit, like rural, they don't have resources. Rural, they're struggling. Rural is poor. But what we often would do is talk about rural from the place of asset, the richness of culture and community in rural areas. I mean, I learned so much about the interconnectedness of people in Mali, the kindness of people in Mali, a very poor country. And I recognized the privilege that we had in South Africa by spending a year living in Mali. And it's the same thing we see. Like for me, when I'm in a rural area in South Africa, I learn about the privilege that I have in the city by immersing in a rural area. Even though I grew up there, of course, you get influenced by your experiences. And when I go back, I have to remember certain things. You know, in the city, we don't greet each other. We pass each other by the street. We don't talk to each other. But in the village, that's what we do. We greet each other. Strangers, we greet them, and we take the time to greet. And they value respect a whole lot more than we do in the city. So now, when you're coming from the city and you're walking into the village and you think that you are better, what does that mean? Better with what? So I often think a lot about, you know, turning what we think is privilege on its head, recognizing the privilege we have when we are in the village, the privilege that I have coming from South Africa and I'm in Mali. There's so much privilege that I obtain from that, not the privilege that I get from South Africa, but the privilege of learning about things I don't know. So I would like to challenge that we think about privilege in a slightly different way. And I do the same with power. Even in terms of power, I think that we think of power in terms of dominion, you know, and we get taught from a young age to dominate, you know, American power, you know, power to dominate other countries. And so even when you're being educated, you're being taught to dominate. The way we are, you know, the school system teaches us to compete and to be better, to dominate other people, to be smarter. Like we have all of these things that are designed in the system for us to assert ourselves over other people. But we ought to challenge that. We ought to challenge the way the system thinks in terms of locating power from a place of dominion. But for me, I'm saying that there's so much power in humility. There's so much power in being able to serve someone else. And I see the privilege in it, but when you've got the power to do it, to help someone else, you know, when you have the power to help someone else and you do that, that's exercising power, not necessarily to dominate that same person. And for me, I think that it's the way that we need to start thinking, and I'm thinking aloud here, but these are the things, conversations that we have to say that it's not about you winning everything. When you help someone to win, that's you exercising your power. But in the process, your power is not in conflict with someone else's place of power. And I think I would stop there, but maybe as food for thought to think about that. I'll comment again about the other question you asked, Emily, but let me give Lucy a chance to share. She's worked a lot more with power than I have.
I'm not sure that I can add much, though, Mosa. I mean, I think that it is. I think that the first part of the question was to do with students and how students approach issues. And I think that it's about approaching with an open mind and with a willingness to learn and with a recognition of the limits that one has. Each of us has limits, and acknowledging that is the first step to being able to engage with others, and then to respecting the other and to generating the space for the magic of learning, of the huge privilege of inquiry and valuing that privilege. And I think, can we translate that sort of set of answers to how global health foundations or organizations work in countries? We should, because they are made up of people. They aren't sort of disembodied beasts. They are made up of people working with others. We have to then think about how, as people, we work with one another and how we use the power that we each have to create a space for shared learning and shared knowledge creation for the benefit of all, not for the benefit of some. Over to you, Emily.
Yeah. So Emily, if I can just comment on the issue of just for the institutions, the global institutions, and let me just kind of share that there's one thing that I have found really powerful, a lesson from Ethiopia, where they talk about this notion of, it's about financing. And they talk about having one plan that is developed with different stakeholders and different interested parties, including funders and aid companies. So they have one plan together. They have one budget. So the state will put forward, this is the pot that we have. And all these other donors, they bring it into that pot. So they work with that one budget. And then they have one report. So they talk about one plan, one budget, one report. It has revolutionized the way I think about how power can be shared. And this is a problem because when you think about organizations that favor bilateral relations instead of sort of this multilateral relations, they have an agenda to pursue. And of course, it's their money, they can do whatever they want with their money. But I will use an example of PEPFAR, and they'll probably hate me for it, but I will use it anyway. Between 2006 and 2008, I had a bad experience with PEPFAR when I was running NGOs that were PEPFAR funded, and we were setting up HIV clinics in rural South Africa. And in 2008, I decided that I am never taking PEPFAR money. And in fact, I decided that I am never taking US money because the strings attached to US money were very problematic for me. And in fact, I felt like you'd rather not have money than take their money because it's going to cause more harm than good, even though it's a lot of money. And don't get me wrong, PEPFAR is one of the best things that the US has done in the world in terms of development, but it is fundamentally problematic. And then I was fortunate enough in 2013 to meet a program officer from the NIH who convinced me to apply for an NIH grant. And in fact, it was a D43 capacity development grant. And eventually I did, because he said, you put in your proposal, they give you the money, they leave you alone. And indeed they did leave us alone. And that was great. And the same person moved and went to work for HRSA. And later on, he wanted to convince me to take PEPFAR money. Now, he still succeeded. And the reason he succeeded was because he put me in touch with people who were trustworthy. And I worked with them. And I still work with them today. I've been working with them for 2 years. And there is so much trust that I feel in the way that we engage. I feel heard. When I raise an issue, they hear what I'm saying. When I tell them we shouldn't do it that way, we should do it this way, they fight the fight that they need to fight with PEPFAR and HRSA and others to make sure that what we are putting forward gets listened to. Now, I would never have thought 10 years ago that I would ever take money from PEPFAR again. And a few years ago also, we evaluated this PEPFAR intervention in Rwanda, the HRH, Human Resources for Health. There's a report from the US National Academies that came out recently that if you don't have, get hold of it and look at it. Very interesting. And it was a huge amount of money that was put over a period of 7 years in Rwanda. And it was supposed to, but it was cut off at some point. There were politics, and I wouldn't go into them. The fact that when pivot happens between PEPFAR 2.0 to PEPFAR 3.0, priorities shift and everything gets cut at that point. It's an issue, it's a big problem. And people are dependent on that funding. So if you don't have that report, go look at it and think about it. But here, the point that I want to make is that here's a funder who prefers bilateral relationships, and they will go to large extent. In Malawi, I was horrified in terms of how much leverage they had in setting the agenda in Malawi. Now, again here, they can't do it. It's their money. And Malawi doesn't really have a lot of options to say no. But in South Africa, we can push back. Rwanda pushes back a lot. Ethiopia can push back because of power issues. But there's so much politics tied to these issues that if you are not aware of them as a young global health activist or even employee or whatever that you, however you position yourself, researcher, you get to play into these agendas yourself and feed into them because you don't know. From a place of, as I said, ignorance, it's unintentional. But we cannot live it like that. You cannot be naive about it. You have to understand the politics and understand how you fit into those politics and choose how you're going to play. And for me, I think that I realize now that we can get around these problems, even at a global level, by building these relationships of trust, and Lucy referred to networks. If you are genuine and interested in, and you respect people, whether they are in an African country or a poor country, or whether they are Black or brown or whatever the case might be, if you choose to respect people and respect their values and respect their agenda and recognize that they have assets, you can still do something different with the leverage that you have, even though you may have your own agenda, because you can put your agenda on the table. They decide whether they take it or not, but don't then set the agenda for them. So for me, I think I just want to highlight that to say that those of us who are in this low income and middle income countries, we have a hard job of playing referee. We have to constantly push back with our partners to make sure that we safeguard the interests of our local communities. Even though, of course, money may be tempting, because then it's nice to have funding, but sometimes that money can cause harm instead of build. So sometimes we have to say no to the money itself. And for us to be able to say no to the money, you need a great deal of power, which is why I am saying that personally, I feel that I'm previously disadvantaged. Now I'm privileged because I can say no. And so, but at the same time, I think that for those who are learning about global health and trying to understand global health, don't be naive, be aware of these things. And when you're engaging with your partners in the so-called global south, listen to them. When they say this is harmful, it is harmful. You need to be able to hear them, and don't then use the power of having money because you control the purse strings to force them into submission. That is oppression. And we have to not do that. And that's what is the problem is with the sort of colonial ideology and mentality to say that I know better, I've got more power, I control the resources, then I dictate the terms. No.
I feel like that was an amazing conclusion to how we should think about decolonizing global health. Lucy, do you have anything else you'd like to add?
I think that what we have done throughout the course of the hour is discuss power and privilege and ways of reversing how we exercise our power and ways of acknowledging our privilege and new types of privilege. And that's at the heart of the decolonial debates and discussions. And I think those debates and discussions give us the opportunity to rethink the world for ourselves in ways that confront the traditional exercise of power. And if we can rethink the world for ourselves and for ourselves exercise power differently moving forward, we will contribute to a new future. Thank you.
Mosa, do you want to add anything else?
No, thank you for the invitation and for engaging. And yeah, it's a real pleasure, and I'm looking forward to see what you guys are going to be contributing to the world into this new future that Lucy is referring to. Thank you.
Well, thank you for sharing this virtual space with us. It's been just such a privilege to have some of your time for an hour and to learn with you. And thank you so much.
Thanks very much, everybody.
Yeah. And
Thank
good
you,
evening.
everybody. Good